Hi, this is Arun Agrawal from Pulmonary and Critical Care, and what you are seeing here is a working prototype of how to ventilate multiple patients with a single vent, and basically we will just call it multi-vent at this time. And if you see here, this is a ventilator which is set up in pressure control mode, and we are ventilating 2 patients. The key thing here is that you can control individual pressure or volume or PEEP, and even find out auto PEEP in individual patient. So those are the key things. I think they were concerns. There is minimal cross contamination, and we can change settings on one patient at extreme levels without changing any significant parameters on ventilation on the other patient. So the way I have put this setting, and I will go in detail with this, is this is ventilator with pressure control mode, and if you see, it is set at 35 of pressure control over PEEP, and PEEP is set at 8 and respirations are set at 18. I have set the ventilator alarms off at this time. However, you can use to set up high peak pressure alarms and all if needed. So again, if you see the tubing, the blue tubing is the inspiratory limb and the white tubing is the expiratory limb. What I have done here is basically I have added a T-piece here, and this is very simple and available anywhere. And the other important thing I would like to point out in this setup is everything except this ball valve, which is the blue valve here, this one, and the blue valve here, this one, which is basically available in any departmental store. This is a 1/4 inch ball valve. Everything is available in the hospital and nothing has been taken from outside. Of course, I got the box from outside, but I think if you search enough, you should be able to find a box in the hospital. So as we all know, as intensivists and RTs, that it is very easy to connect multiple patients on ventilator, but the key thing is how do you control the individual parameter. And the way I have achieved that is the blue tube basically goes to the patient, which is the, of course, inspiratory limb, and will, for simplicity's sake, we'll start with this patient number 2 here. The blue tubing is connected to one-way valve, and I'll come into detail why this one-way valve is there, which is again connected to valve which I just described. This is 1/4 inch of a valve which is connected to the Y piece, and this is connected to an HMA filter which also acts as a humidifier. So you don't need humidifier in this setup. And here we are ventilating one lung, and the expiratory circuit here I have attached a peak valve. And the reason for the peak valve, basically this is a peak valve available in the hospital, and it is usually goes on ambu bag, but also you can use any peak valve here. And this is the picture of the peak valve. This would actually control individual PEEP in this setting. So this completes the circuit. Now on the other patient, if you see, the inspiratory limb goes to a modified incentive spirometer, and again the valve is in place here, again the blue valve, and these adapters, basically if you see, these are the 2 adapters here. One is the multi-adapter 15 into 22 millimeter, and the other one is 22 into 22 millimeter, and these adapters basically can be are readily available and part of the hospital setup of ventilator. And this is the adapter. Basically this is a, I think this is the 15 millimeter, yes, 15 into 22, and then we have the 22 millimeter adapter, which comes in 2 forms. One is the plastic one which I have used, and you can see it right here. That is the adapter, the plastic one. So back to the ventilator. With these adapters, see, there's no other adapter used here. Of course, there's a one-way valve again here, like in the previous setup, and it goes to a modified incentive spirometer, and this is an optional equipment to measure the accurate volume, especially if you're ventilating a patient who has ARDS. And the way the setup is, one very important thing is it has to be airtight and rigid. That is very important thing. Otherwise, if air leaks, then this may not work as well, though it may still work. You have to connect the spirometer in opposite way, and basically what this is then the spirometer is in a box, and the inspiratory limb, this one, actually just opens inside the box in an airtight manner, which I have used these black washers, and then the tubing of the incentive spirometer opens outside again through airtight tubing, so that the box is airtight, and basically completes the circuit to the Y tubing again with the HMG valve, and then to the patient. Now, if you see where the endotracheal tube is, we have attached a suction tubing, but I have cut the suction pipe, and I have actually attached this manometer to the suction tubing, and this manometer basically is measuring the pressure directly to the patient up to the endotracheal tube. So actually it is more sensitive than the ventilators and some of the newer ventilators or older ventilator itself, where they measure pressure directly at the ventilator, but what we are doing is measuring pressure at the patient, and that is very again important, because if you see, I can see the PEEP here, which is 8 around, which is the PEEP of the ventilator. And this one is also, if you see, the PEEP comes to around 8 again, and the peak pressure is here 20, and here in this patient the peak pressure is around 22. Yep, 22 to 24. So this completes the setup. Now the drawbacks of the other setups are not present, and I have tried to minimize the drawbacks in this setup, where you can control the volume or pressure. So let's see, we have already seen these settings. What I'm going to do is change this valve to control the volume to around 750. So it's at 500. I open this valve and it goes to 750 a little. Now if you see, the pressures of course have increased, because we wanted to increase the pressure. We opened the valve to 34, but if you see on the other patient, the second patient, the PEEP stays at around 8, the pressure around 20. There is not even a single digit pressure change in the other patient, and the ventilation is the same way. Okay, and then let's decrease the, let's say the patient has ARDS or develops ARDS, so we need to decrease the minute volume. So we decrease the pressure. So it's like around 300. So we decrease the volume to around 300, 350. And let's see what happens to the pressure or the volume on the other patient. The pressure stays the same exactly. The volume stays the same. Of course, we are not measuring the volume, but since the pressure and compliance has not changed, the volume has to be same. And we can of course add this spirometer again in this circuit too. We can add it in any circuit basically to measure those volumes. So see, by changing the volumes on one patient or pressure on one patient, nothing changed on the other patient. So again, let's say if you want to change it to 500 again, so basically we can just change it depending on what the patient needs. Yep, it's 500. Now let's play two scenarios where, let's say this patient is not doing well and codes. So basically I'm turning the valve off. no pressure, no valve. We have taken this patient off the ventilator to bag and mask him. Nothing has changed on this patient. Let's see the volume. Not changed, or not significantly changed, I would say. There may be slight variation, but usually, and that is like in extreme scenarios. Now, let's say this patient develops a leak or develops pneumothorax. So I'm going to open it fully. So his pressures have changed dramatically. 30 to 40. Now let's see here, the volume has changed. This patient suddenly either has developed a leak or his lungs have become very compliant. Let's see what happened to our other patient, how much the volume changed. None at all. How much did the pressure change? Very similar. And we can again control the pressure. So that is the key thing about these patients. If we ventilate them in this way, there's a way we can ventilate them with individual parameters. Now the other important thing about this is, let's say that patient requires higher PEEP. Now we have a PEEP of 8 on the ventilator, and both patients are getting approximate PEEP of 8, right? And you can see it here, it's very accurate actually. If you measure that, it's coming to around 8. So what I'm going to do is I'm going to change this patient's PEEP to, with the PEEP valve. This is again a little cumbersome, to 10 or 12. I'll have to stop a video for a second and change it. So I have changed the PEEP to around 12. So if you see, the patients have different PEEP now. This patient has a PEEP of 8 and the other patient has a PEEP of 12. And you can change it to higher levels up to 20, 25, whatever you desire depending on this valve. So I'll try to do it with one hand, but try to change the PEEP again to higher level. And I think I need my both hands, but I'll try. Okay, I think I have to use my, yep, here we go. So I have changed the PEEP here to much higher, to around 18. Okay, so thus we see that we can change the patient's PEEP and a volume or pressure without changing the pressure on any other patient basically. Now let's, again, this patient, let's decrease his compliance and make him normal. Okay, and see, there is no change in the other patient. So thus we see that we can actually change the pressure and volume and PEEP, and actually measure auto PEEP without changing any other parameter. So we can extrapolate this to 3 or 4 patients. The ventilator can go up to with a tidal volume of 4,000. So theoretically you can combine around 8 patients, but I would suggest probably we do 4 or 5 at the most. And with this setup, this is a disaster setup, and we should be able to ventilate patients though who are otherwise going to not survive because of lack of ventilators. This is very important because if you have an older patient and there are younger patients too, I don't want to be in that situation where I cannot offer anything, at least to the older patients, and hopefully this would buy us some time or help us to ventilate patients till we get more ventilators. Please feel free to ask me any questions. I will also put in the comments about different caveats and the way certain problems that I encountered please see that you need to put the one-way valves right in that position where I have put it, and the reason is because there are multiple patients here, and one's back pressure or PEEP may affect the back pressure of others. So the valves have to be in position, and that is another key thing for the patient not to affect another patient. So both it has to be in inspiratory and expiratory limb. If you see, this is a one-way valve which is readily available, and that is another one-way valve in the inspiratory limb. Same thing is happening with this patient. This is a one-way valve, this with the arrow, and then on the expiratory side this is a one-way valve. Again, please feel free to ask me any questions, any concerns about this setup, and I'll put that in the documentation too and in a diagram, so we can probably help save some patients who they should not die because of lack of ventilators. Thank you very much, and just a few comments here. There is some concern about cross contamination, so you should have these HMG valves or other valves. Even if you don't want to use this HMG valve, this actually serves a dual purpose, avoids cross contamination and also humidifies air for the patient. So I have used these here, but you can use other valves, and the ventilator also has a HEPA filter, so there should be least cross contamination. Please feel free to comment and forward this video to healthcare authorities and healthcare people who are in dire need of ventilators. I cannot officially or the organizations cannot officially at this time can endorse this video because it has not been tested on humans, but currently if you are in a situation where a person is not going to make it because of the lack of ventilator, I don't think we have any other choice. Hopefully none of my colleagues has to use this setup. That is my wish, but we should also be prepared, and it is a very easy setup to make provided we do it the right way, and should do the trick. Again, the alarms should be on the patient monitor for oxygen and not on the ventilator, and also you can put an alarm for respiration there to check for apnea. So on a patient monitor, if we set alarm for, let's say, respiratory rate less than 6 or oxygenation less than 89%, we should be able to almost mimic apnea alarm on the ventilator. Again, thank you very much, and please feel free to add comments or questions.